Changes in function of the motor system are the most frequent cause not only of back pain, but also of headache, shoulder, thoracic and pelvic pain, and pain in the extremities. This is not due to permanent, that is, structural lesions, but only to changes in function which are reversible only if we know how to diagnose, analyze, and then normalize the very complicated function of the motor system. Mobilization and relaxation techniques deal with disturbance of muscular and joint function. Relaxation techniques are used against increased muscular tension, that is spasm, and in particular myofascial trigger points and at muscle attachment points. Mobilization techniques restore joint mobility. The two are interconnected. Joint movement restriction goes hand in hand with muscular spasm, in particular with trigger points which restrict movement. It is important that patients very often can treat their own lesions by relaxation techniques. These techniques are very gentle and painless.
As time is short, we'll start by showing one technique at the correct speed, but techniques in the rest of the video series are demonstrated faster. This is post-isometric relaxation of movement restriction in the lumbar spine. When examining individual segments of the lumbar spine, we can observe increased resistance in the segment L5-S1. The general procedure of PIR is: first, we move the joint to the point where we can feel the first minimum resistance, i.e., we take up the slack. In this case, the slack is taken up by slight pressure by our fingers with counter pressure of our thigh against the patient's knees into lordosis. He then is told to press his knees slightly against isometric resistance of our thigh for about 5 to 10 seconds, resulting in kyphosis. We then say, "Let go," and after a short latency, we feel the patient relaxing into lordosis. If the range of motion increases, we wait as long as relaxation goes on, for 10 seconds or even longer. If, however, we decide that relaxation isn't sufficient, we repeat the procedure from the position we have gained. Push again slightly with your knees against my thigh. Take a deep breath, hold your breath, and then let go and breathe out. This can be repeated until the range of motion no longer increases. This basic procedure is usually combined with other techniques. In the first place, with eye movements to the sides or up and down, with inhalation and exhalation, and finally by making use of gravity. First, eye movements. If trunk rotation is restricted to the right, we instruct the patient to look to the right so as to reach the pathological barrier which restricts movement. Then follows look to the left, as we put up isometric resistance against his gentle movement and hold it for about 10 seconds. Then the patient is told to look to his right and relax. From the position gained in this way, the maneuver is repeated. The instructions will be thus: look to the right. Now look to the left and take a deep breath. Hold your breath and look to the right. Relax and breathe out. Once again, look to the left. Breathe in, hold your breath, and look to the right. relax, and breathe out. In a similar way, we can make use of looking up and down to obtain straightening up or bending down from a stooping and even from a side bent position. Relaxation of short neck extensors will be demonstrated as an example. The patient is told first to look down and from that position to look up and resist automatic straightening up. After 10 seconds, he is told to look down to obtain relaxation of the extensors. Inhalation and exhalation have an even more important influence on the trunk musculature. In most cases, inhalation produces facilitation and exhalation inhibition of muscle activity, but there are exceptions to this rule. In addition, it's important that looking up facilitates inhalation and looking down exhalation. Holding the breath prolongs the facilitative phase. Therefore, when we want to relax the extensors of the craniocervical junction, we always combine looking up with inhalation and looking down with exhalation. To slow down the procedure, we ask the patient to hold his breath. Hence our instructions. Look up and breathe in slowly. Breathe in, hold your breath, and now look down and slowly breathe out. Whenever we can, we make use of the influence of gravity at the extremities as well as with the head and trunk. This we can show on the triceps. The patient has his bent elbow raised above his head and now lifts his forearm to the horizontal and holds it in this position for 20 seconds. He then drops it on his head to relax for another 20 seconds. This, obviously, is self-treatment from the start. PIR method is immediately combined with reciprocal inhibition, which the patient can exercise himself by exerting strong pressure into the opposite direction. Once the patient has relaxed his triceps with the help of gravity 2 or 3 times, he is told, "And now press your hand down on your head." In this way, the biceps is stimulated, inhibiting its antagonist, the triceps that was in spasm. Alternatively, we make use of not constant but repetitive slight pressure. In this case, the patient is told to push his hand down on his head rhythmically. Using the reciprocal inhibition method, we stimulate antagonists of the muscle in spasm. Instructions for PIR of the triceps will then be: bend your arm at the elbow and raise the arm above your head. Lift your forearm over your head, hold it, and now drop it on your head and relax. And now push your hand on your head. At this point, the combination of all these methods can be demonstrated when relaxing the quadratus lumborum. Bend to your side and relax completely. In this way, the slack is taken up. Now look up and take a deep breath slowly. If the patient is well relaxed, deep inhalation alone will make him straighten up. Look down and breathe out slowly. Now he side bends even more as he relaxes. After 2 to 3 repetitions, the instructions are: now push your hand down towards the floor. temporomandibular joint with the masticatory muscles represents a functional unit. Therefore, we usually have to diagnose and treat both. If there's abnormality, the patient is usually not able to put 3 knuckles between his front teeth. On opening his mouth, we have to look whether he does not push his chin forward or whether it deviates to the side. Painful trigger points are palpated on the temporalis, the masseter from outside, on the internal pterygoid at the angle of the mandibula, and on the external pterygoid from inside the mouth above the last molars. This is usually the most painful. Increased tension can be palpated on both sides of the hyoid, and we can sense increased resistance on moving the thyroid cartilage to the side opposite to the contracted digastricus. If this contraction is marked, we frequently see deviation of the thyroid cartilage towards the side of the contracted muscle. These patients often complain of headaches, facial pain, vertigo, and problems when speaking and swallowing. For relaxation of most of the masticatory muscles, we place our palm on the patient's chin from above or on his lower front teeth. The patient opens his mouth so as to take up the slack. Now he is told, breathe out, followed by, take a deep breath, breathe in, open your mouth like a yawn. This is repeated 2 or 3 times. For self-treatment, the patient puts his elbow on a table, holding his head between the thumb and forefinger from below. His head should be neither too much in anteflexion nor in retroflexion. He opens his mouth, puts his fingers on his lower front teeth, and exhales. Then he breathes in and opens his mouth wide. Breathe in, and open your mouth as wide as you can, and relax, and breathe out. For relaxation of the external pterygoids, the patient is supine. He slightly opens his mouth, and we place our thumbs on his chin from above. Push your chin forward and breathe in. Breathe in, hold your breath and relax, and breathe out. During relaxation, the chin moves in a dorsal direction. For self-treatment, the patient does the same against his own thumbs. Push your chin forward and breathe in. Breathe in, hold your breath, and relax, and breathe out. For relaxation of the digastricus, the patient lies supine. We place one hand on his chin from below to resist opening his mouth. The thumb of the other hand on the side of increased resistance is placed against his hyoid from the side touching it with minimum force. Open your mouth with little force and breathe in. Breathe in. And now relax and breathe out. During relaxation, the mouth closes and we can sense the resistance at the thumb melting away. For self-treatment, the patient sits, his elbow on the table and his chin supported on his palm. The thumb of the other hand touches the hyoid from the side. He now opens his mouth against resistance, breathes in slowly, then holds his breath. During relaxation, the mouth shuts and he feels that resistance at his thumb is decreasing. For distraction mobilization of the temporomandibular joint, our thumbs are placed on the lower molars from above and the flexed forefingers below the patient's mandible on both sides, making use of leverage to carry out traction. During traction, we can perform a rocking movement on either side for mobilization. If mouth opening is not properly coordinated, the patient puts his tongue against the palate behind his front teeth and slowly opens and shuts his mouth, keeping his tongue against the palate. This trains coordinated mouth opening. The segment between occiput and atlas is examined in all directions, including joint play. Joint play consists mainly in a translatory movement of the occipital condyles against the atlas in an antero-posterior direction. Its examination serves as a screening test. We grasp the head between our arm and thorax with the patient seated, his forehead against our elbow. The other hand fixes the posterior arch of the axis. We move his head back very gently to take up the slack and then spring the joint. Movement is possible only between occiput and atlas. We now examine pain points at the posterior arch of the atlas, where the trigger points of the short neck extensors are located. Pain points at the nuchal line, at the posterior edge of the foramen magnum, pain points at the transverse process of the atlas, and at the mastoid process, which is the attachment point of the sternocleidomastoid. Pain points at the lateral edge of the spinous process of C2, which we examine with the head at side flexion. Mobility is examined in all directions. Into anteflexion, the patient is supine. We fix the transverse process of the atlas with our thumb and index finger. After taking up the slack into anteflexion, we spring the joint and make sure of correct fixation simply by loosening our fingers. With the head rotated, we can side bend the patient's head to take up the slack and then spring the joint. Similarly, with the head rotated, we examine retroflexion. Rotation is examined with the patient seated and the slack is taken up by maximum rotation with minimum force. From this position, we spring the joint into rotation, again with minimum force. Springing is felt both with the hand which rotates the head and with the other hand at the atlas transverse process. Mobilization can be carried out from the same position. However, mobilization into anti, lateral, and retroflexion is more useful. For mobilization into anteflexion, the patient is given the following instructions. Look up to your forehead and breathe in. Breathe in, hold your breath, and look down to your chin and breathe out. Relax. We must sense his relaxation. Look up to your forehead and breathe in. Breathe in, hold your breath, and look down to your chin and breathe out. The same instructions are given for lateral flexion. Look up to your forehead, breathe in, hold your breath, look down to your chin, and breathe out. Mobilization into retroflexion, too, is carried out with the head rotated, but the patient is only told, breathe in, hold your breath and relax, and breathe out. This mobilization is particularly effective in increasing the range of movement. Each of these mobilizations is repeated until relaxation is satisfactory. For self-treatment into anti- and retroflexion, the patient is seated, his head turned to the side. He looks up to take up the slack and, breathing in, forcefully bends his head back, then looks down and, after taking up the slack, he breathes out forcefully and bends his head forward. For self-treatment into side bending, the patient is supine with his head over the end of the table, turned to the side. The mastoid process and the mandible are supported at the end of the table, taking up the slack by relaxation. He now looks up to his forehead and breathes in slowly, holds his breath, and then looks down towards his chin and breathes out. Contraction of the SCM during inhalation lifts his head. And relaxation during exhalation makes it drop again into side bending. This is repeated 3 times. Muscular relaxation at the craniocervical junction is done in order to treat painful trigger points located in the short neck extensors. The trigger points must be first found by careful palpation. For relaxation, the patient is seated, his back supported against our thorax. We first bring his head into anteflexion at the craniocervical junction, forward nodding, so as to take up the slack. Look up and breathe in. Breathe in, hold your breath, and look down and breathe out. In order to avoid anteflexion of the entire cervical spine and to restrict it to the craniocervical region, we have to step back a little so as to let the patient slip down along our trunk. For self-treatment, the patient is seated in a low back chair. He brings his head into anteflexion by nodding, with his thumb on the zygomatic bone and his fingers on the occiput, taking up the slack. He looks up and breathes in slowly, holds his breath, and then looks down, increasing forward nodding, and at the same time bending back over the back of the chair so as to restrict anteflexion to the upper cervical. Trigger points in the sternocleidomastoid are examined by pincer movement. If there are trigger points in the SCM, the same technique is used for relaxation as is for side bending self-mobilization of the occiput against the atlas. The patient looks towards his forehead and breathes in and holds his breath. During this phase, the sternocleidomastoid contracts and the head is lifted. Then he looks towards his chin and slowly breathes out, and the head drops into lateral flexion and the SCM relaxes. Here again, we can see how the SCM contracts during inhalation and relaxes during exhalation. Mobilization of the atlas against the axis is best achieved by lateral flexion, which produces axis rotation. The patient is supine, and we grasp his head with both hands at the end of the table. To take up the slack, we side bend his head by rotating it round an axis through the root of his nose. Then we spring the joint to establish the diagnosis of movement restriction. C12 is the odd segment, which means breathing out in. During exhalation, resistance in the segment increases, and in the course of inhalation, relaxation takes place. For mobilization, the patient is told to breathe out, thus increasing resistance. This is followed by breathe in, and after a short latency, release is obtained. Breathe out, and now breathe in deeply. Restricted rotation of C1, C2, C3 is best mobilized by Lewit's maneuver. The patient is supine and his head exactly in midline. If right rotation is restricted, we exert pressure against his left shoulder from above. The patient is told to resist our pressure. Push up and slowly breathe in. Hold your breath. During this phase, we stimulate at the acromion, followed by relax and breathe out. During relaxation, the shoulder moves in a caudal direction. Push your shoulder up and breathe in. Hold it. Relax and breathe out. As movement is restricted to the right, carried out on the majority of cases, and only exceptionally on the right side. After the upper cervical spine, we shall deal now with the rest of the cervical spine. The most important structures are vertebral bodies with the processus uncinati, the intervertebral discs, the intervertebral joints, the transverse, and the spinous processes. Pain points are usually found on spinous processes, the articular processes, and in the deep layers of the paravertebral muscles. These points can be palpated with the patient seated, even better, supine. Mobility is first examined by side bending with the patient seated. We proceed from C2 down from segment to segment and notice how the range of movement increases and feel any resistance. This can be also done with the patient supine. For mobilization, we make use of Gaiman's rule. We distinguish even and odd segments, C0, C2, C4, C6, and C1, C3, and C5. In the even segments, resistance increases during inhalation, and mobilization is facilitated during exhalation. On the contrary, in the odd segments, resistance increases during exhalation, and mobilization takes place during inhalation, as we saw in segment C1, C2. Therefore, in an even segment, such as C2, C3, the patient is told, look up and breathe in, hold your breath, followed by, look down and breathe out. On the other hand, in an odd segment, for example C3, C4, we say, look down and breathe out, followed by breathe in slowly. Release follows automatically, but we have to wait for it during the relaxation phase. This mobilization can also be carried out with the patient supine. Self-treatment is most convenient into lateral flexion. The patient resists lateral flexion in segments C1 to C3 with his palm and in the lower segments with 2 fingers, and makes use of Gaiman's rule. Here we see self-treatment in segment C2 to C3. After taking up the slack into lateral flexion, the patient looks up and breathes in slowly, holds his breath, and then looks down and breathes out. In segment C4 to C5, he uses 2 fingers. Otherwise, the procedure is the same. Rotation of the cervical spine is examined with the patient seated. We fix the arch of the lower vertebra of the movement segment between our thumb and forefinger and begin at C2. The range of movement increases as we proceed from segment to segment. Where there is no increase, we also feel resistance and diagnose movement restriction. For mobilization after taking up the slack, the patient is told, look up and breathe in, hold your breath, followed by look down, and breathe out. The other option is look to your left and breathe in, hold your breath, followed by look to your right and breathe out. This is repeated 2 to 3 times. For cervical traction, we regularly make use of post-isometric relaxation. This is indicated mainly in acute wry neck, in root pain, and also in C2 to C3 movement restriction. The patient may be supine or seated. If supine, the patient's head is over the end of the table, cradled in our hands. Look to your forehead and breathe in. The patient inhales until we see his SCM contracting and feel the tension in our hands, and look to your chin. Breathe out and relax. Look to your forehead and breathe in. Hold your breath and look to your chin. Breathe out and relax. This is repeated 2 or 3 times. Seated, the patient is safely supported by the therapist so as to relax. The hands of the therapist softly cradle the patient's face and occiput, his elbows on the patient's shoulders. Look up and breathe in. The moment the therapist feels increased resistance, he tells the patient to hold his breath, breathe out, and relax. Look up and breathe in. Hold your breath, breathe out, and relax. By its function and clinical signs, the cervicothoracic region is part of the cervical spine. It's formed by vertebrae C7, T1, and T2. The most important pain points are at the spinous processes C7 to T2, at the upper ribs, at the upper edge of the scapula, and in the muscles of the shoulder girdle, in particular in the upper and middle part of the trapezius. And Erb's point on the scalenes. Movement restriction is examined first by a dorsal shift of the upper vertebra. The patient is seated on a low chair. We grasp the patient's head from above, between our arm and our chest, with his forehead against our elbow and our hand against the upper trapezius on the shoulder. The thumb of our other hand fixes the spinous process of the lower vertebra. By pressing our hand on the trapezius, the slack is taken up and the segment is sprung by a sudden increase in pressure on the trapezius against the resistance of the thumb on the spinous process. For lateral flexion with our fingers on his zygomatic bone, we first move the patient's head into retroflexion, then into lateral flexion, and finally into rotation in the opposite direction, which brings our thenar against the spinous process of the upper vertebra from the side. The thumb of the other hand resists at the side of the spinous process of the lower vertebra. We now spring with the thumb at the lower vertebra against the thenar at the upper vertebra. The same position serves for mobilization. After taking up the slack, the patient is told to look up and breathe in, hold your breath, and now relax and breathe out. During relaxation, lateral flexion increases and the thumb at the lower vertebra provides fixation. With the same technique, we can also deliver a thrust by our thumb after taking up the slack. This technique is very effective, but technically difficult. Look up and breathe in, hold your breath, and now relax and breathe out. It's easier to mobilize the patient as he lies on his side. With the patient turned towards the therapist, we grasp his head so that his forehead lies against our elbow and our little finger is round the arch of the upper vertebra of the movement segment. With our elbow on the table, we push the head gently back. In this way, we automatically take up the slack into retroflexion, side bending, and rotation to the opposite side. The thumb of our other hand fixes the spinous process from above. Look up to your forehead and breathe in, hold your breath, and relax and breathe out. During relaxation, our elbow shifts in a dorsal direction, automatically increasing back and side bending and rotation to the opposite side. A thrust can be delivered by the same technique. Rotation mobilization with the patient seated is a very easy technique. If we are rotating to the left, the patient sits on a low chair and we grasp his head from behind with the left hand and press it against our chest. Our elbow is at the height of the patient's forehead and our little finger round the arch of the upper vertebra of the movement segment. The thumb of the other hand fixes the lower vertebra from the side. By gentle rotation, the slack is taken up and the patient is told, look to your right and breathe in, hold your breath, and look to your left and breathe out. The range of motion increases automatically. A thrust can be delivered with the same technique. The thrust manipulation we most frequently use is with the patient seated with the back well supported by the therapist, his hands crossed behind his neck. We thread our hands through his elbows so as to place our fingers on the spinous process of the upper vertebra of the movement segment. The patient lets his head drop forward to produce kyphosis at the cervicothoracic junction and exerts slight pressure with his elbows against our forearm. We now press our sternum against the caudal vertebra and simultaneously give a thrust with the sternum and with our fingers on the upper vertebra. This technique can be used throughout the cervical spine up to C3 without using the sternum. This is the safest of all thrust techniques. For self-mobilization, we use a technique which produces movement at the cervicothoracic junction by simultaneous head rotation and turning of the arms. The patient is seated with both arms slanting down and fingers stretched apart. One thumb is pointing up and the other down. The patient looks towards the thumb pointing down. He now simultaneously turns his head and his arms, looking towards the side where the thumb points down rhythmically. 1, 2, 1, 2. He must not lift his shoulders. This is a very useful alternative technique. The patient is seated, supported by a padded chair back which is sufficiently high for the patient to lean his cervicothoracic junction against the top. To take up the slack, the patient moves his head and neck horizontally against the back of the chair and then springs the cervicothoracic junction rhythmically. Techniques of muscle relaxation in the cervical region. We start with the upper trapezius. On the picture, we can see locations marked by an X where trigger points are situated most frequently. Referred pain areas are in red. Trigger points in the upper trapezius are examined by snapping palpation between our fingers. Relaxation. The patient is supine. We fix his shoulder with one hand, and with the other we side bend his head to take up the slack. Look to the right and breathe in. Breathe in. Hold your breath. Relax. And breathe out. This is repeated. Look to the right and breathe in. Breathe in. Hold your breath, relax, and breathe out. Look to the right and breathe in. Breathe in, hold your breath, relax, and breathe out. For reciprocal inhibition, he side bends against our repetitive resistance. Levator scapulae. Clinically, we find tenderness at the lateral edge of the spinous process of C2 and at the upper margin of the scapula. There are trigger points at the angle between the shoulder blade and the neck. For relaxation, the patient is supine. He raises his flexed elbow, which we push in a caudal direction and fix with our thigh. With our hands, we side bend and slightly lift and rotate his head to take up the slack. From this position, the patient is told, look to the right and breathe in. Breathe in. Hold your breath and relax and breathe out. Look to the right and breathe in. Breathe in. Hold your breath and relax and breathe out. Here again, post-isometric relaxation is combined with reciprocal inhibition. In our case, the patient pushes his head towards the left and the therapist exerts repetitive pressure against the head. Alternatively, in cases where the patient cannot easily lift his arm, we pull his shoulder in a caudal direction with one hand, and with the other, we bring the head into lateral flexion and slightly lift and rotate his head to the right in order to take up the slack. The patient is now told, look to your left and breathe in. Breathe in, hold your breath, and relax, and breathe out. This is repeated. Self-treatment of the upper trapezius and levator scapulae is done simultaneously. We make use of gravity, eye movement, and respiration. The patient is seated with his arms over a low chair back. He looks up, lifts his shoulders, breathes in slowly, holds his breath, looks down, and breathes out, relaxing. Look up and breathe in deeply. Hold your breath, look down, and breathe out. For our eye, he pushes his arms towards the floor. Trigger points in the middle part of the trapezius muscle are found close to its insertion at the scapula. It palpates like a hard rope during maximum abduction of the shoulder blade. This muscle is active, especially in acute cervicobrachial and root syndromes, when the pain radiates into the shoulder blade or upper extremities. PIR is done with the patient seated. The upper extremity on the affected side is brought into maximum adduction towards the opposite shoulder. During inhalation, the patient exerts pressure into abduction, relaxing into adduction while breathing out. The same technique can be used for self-treatment. However, the technique which makes use of gravity is more useful. The patient lies on his side at the edge of the table, his upper extremity on the affected side hanging perpendicularly down towards the floor. He lifts his elbow and breathes in, holds his breath, then lets his arm drop and relaxes in the course of exhalation. For reciprocal inhibition, the patient pushes his arm perpendicularly down. If the scalenes are involved, we find a trigger point at Erb's point. There is referred pain at the upper extremities and at the ventral aspect of the thorax. On examination, we find restricted retroflexion of the rotated head. With the patient seated, we achieve relaxation by retroflexion of the rotated head so as to take up the slack. The patient is supported at the shoulder from which the head is rotated. Look to your left and breathe in. Breathe in, hold your breath, followed by look to your right and breathe out. Movement of the head is resisted with minimum force, but with our other hand on the thorax, inhalation is resisted forcefully. After a short latency, a high quality of relaxation is the rule, even if there's pain. Self-treatment is simple. The patient lies on his side and lifts his head, breathes in slowly, holds his breath, then lets his head drop on a cushion and breathes out. He repeats this, and then for our eye, presses his head down. However logical this procedure, it's usually insufficient. This is so if tension in the scalenes results from faulty respiration, the patient lifting his thorax instead of widening it. In most of these cases, we have to teach the patient correct respiration. Trigger points in the supraspinatus are situated in the fossa supraspinata. Resisted abduction produces pain at the tuberculum majus of the humerus. Relaxation of the supraspinatus takes place with the patient seated. The slack is taken up by adduction of the arm in front of the patient's chest. Push with your elbow against my cupped hand. Breathe in, hold your breath, let go, and breathe out. Push with your elbow. Breathe in, hold your breath, let go, and breathe out. This is repeated, followed by RI, abduction against repetitive resistance. For self-treatment, the position is practically identical. Grasp your elbow in your cupped hand. The patient brings his elbow into adduction to take up the slack. Then, breathing in resists abduction, followed by relaxation into adduction while breathing out. After repeating the maneuver, he adducts against resistance by the other arm. Trigger points of the infraspinatus are a frequent cause of shoulder pain. They are found in the fossa infraspinata. Resisted external rotation produces characteristic pain at the tuberculum majus of the humerus. For relaxation, we make use of gravity. The patient lies supine, the arm abducted and the elbow flexed, with the forearm in internal rotation. He slightly raises his forearm above the horizontal for 20 seconds, and then lets it drop for 20 seconds, relaxing. This he repeats. And for RI, he actively presses his forearm down. Trigger points of the subscapularis are found deep in the axilla, and palpation is very painful. They are a frequent cause of pain in the shoulder, referred pain to the upper extremity, and chest. For palpation, we have to pull the patient's abducted arm, and with the fingers of the other hand, we slip over the latissimus dorsi to the ventral aspect of the shoulder blade. For relaxation, we make use of gravity. The patient is supine, the arm abducted and the elbow flexed with the forearm in external rotation. He slightly raises his forearm above the horizontal for 20 seconds and then lets it drop for 20 seconds, relaxing. Lift your forearm slightly, hold it, and now let it drop. Relax. This is repeated, and for RI, he actively presses his forearm down. If, however, abduction is restricted, he has to turn to his side and abducts and rotates the forearm only as far as he possibly can. He then continues in the same way, lifting his arm and then dropping it into relaxation. Lift your hand. Hold it in this position. Hold it and let it drop and relax. The next muscle group covers the deep neck flexors, musculus longus capitis, longus colli, rectus capitis anterior, and rectus capitis lateralis. They belong to the deep stabilization system and may be weakened by trigger points. They can be palpated underneath the SCM. For relaxation, we make use of gravity with the patient seated or supine. When seated, the patient slightly extends his neck so as to inhibit the SCM. From this position, he draws his chin in and breathes in, holds his breath, and then relaxes into extension. After 2 or 3 repetitions, he makes a forced extension for reciprocal inhibition. Relaxation supine may be easier. The patient lies with his head on the edge of the table, supported by his mastoids, and relaxes into extension. From this position, he draws his chin in, breathes in, holds his breath, and relaxes into extension. For reciprocal inhibition, he extends his neck forcefully. The deep neck flexors are part of the deep stabilization system, and their weakness is thus of great importance. Trigger points in the long superficial muscles are frequently a compensatory phenomenon for the weakness of the deep neck flexors. This can be examined by head anteflexion with the patient supine. Here we see correct neck flexion, with the deep neck flexors functioning normally. If these muscles are weak, the SCM contracts too soon, and there's a tendency to draw the head forward. To train the deep flexors, the patient is supine, with 2 fingers under the cervical spine. The other hand palpates contraction of the SCM. He now exerts pressure with his fingers against the cervical spinous processes and counter pressure against his fingers, but only to the moment when the SCM starts contracting. The first rib. By its function and clinical signs, it forms part of the cervicothoracic junction. If it's abnormal, the patient suffers most frequently from shoulder pain and signs of upper thoracic aperture involvement. If there's movement restriction, we frequently find a pain point at the first sternocostal junction. There's increased resistance upon springing the first rib from above, and on anteflexion of the rotated head with the forefinger, creating a hypomocleum above the clavicle. For mobilization, the patient is seated. One hand fixes his shoulder from the side, the other hand exerts rhythmic pressure against his head from the side which is resisted. This produces rhythmic contraction of the scalenes, which mobilize the first and second rib to which they are attached. For self-treatment, the same technique can be used, the patient exerting rhythmic pressure against his own head from the side. Mobilization can also be carried out by springing the first rib from above or by fast shaking from above, or even by a thrust in the same direction. So far we have dealt with mobilization and relaxation techniques at the head, the cervical spine, and the cervicothoracic junction. This chapter is followed by others explaining mobilization and relaxation techniques in the area of the thoracic and lumbar spine, as well as the pelvis.